Hi, I'm Dr. Michelle O'Donoghue. I'm here at ESC Congress 2022. We are back in person, which is great. There's been a lot of terrific science, and one of the late-breaking clinical trials that will be presented will be by my friend and colleague, Dr. David Berg, who is an investigator at the TIMI Study Group, and he'll be presenting the top-line results of a trial called COVID-PACT, on which I am a co-author. But I thought it was very interesting just to talk about this topic in general, as it still remains an interesting one. Welcome, David.
Thank you, Michelle. It's a pleasure to be here. Thank you for having me.
So let's talk a little bit about the question being asked. Why do we think about clots in the context of COVID?
Yeah, no, I think that's a great question. So relatively early on in the pandemic, it was appreciated that patients with COVID-19 have an increased risk of developing blood clots. And that risk is particularly concentrated in patients who require ICU level care. The exact mechanisms underpinning that increased thrombotic risk are still being sorted out, but there's probably multiple things that contribute to it. And one of the interesting findings has been that that increased thrombotic risk is held constant over time. So even with the introduction of effective therapies and vaccines, if you benchmark the risk of thrombosis in COVID-19 to other viral infections like influenza, that increased thrombotic risk has been constant over time.
Yeah, it's interesting. It does raise many questions about, whether or not the type of virus, has there been any change over time in terms of clotting risk since the start of COVID towards more recent cases?
Yeah, no, I think that's a great question, and there really has not. So some of the early epidemiologic data suggested very high rates, but that came from case reports and case series. So within a few months, when larger epi studies were published, it was appreciated that rates of thrombosis in ICU patients were on the order of 10 to 30%. And even with the introduction of effective therapies, that's remained the case.
Right. So what does the evidence show so far leading up to COVID-PACT? What do we know about different treatments and their effectiveness and their safety?
Yeah, we, as you can imagine, there was a lot of enthusiasm to try to understand the effect of antithrombotic therapy in COVID-19 once it was appreciated that there was an increased risk of thrombosis. And so there have been a number of randomized trials to date that have answered exactly that question or explored that question, looked at increased intensity anticoagulant therapy or antiplatelet prophylactic strategies. And I'd say that the primary results of those studies have been mixed in large part because of differences in study designs and the patient populations, and in particular, the study endpoints. In particular, there was one large study called the multi-platform trial, which combined a couple different trial platforms. And there were separate studies in critically ill and non-critically ill patients. And the primary endpoint in that study was an organ failure endpoint. So it was number of days alive off organ support through 21 days. And surprisingly, there were different results in the critically ill and non-critically ill patient population. So in non-critically ill patients, the study was stopped for superiority of full dose anticoagulation. Both of them had the same design, therapeutic dose anticoagulation as compared with standard dose prophylactic anticoagulation. And there was a benefit of full dose anticoagulation in the non-critically ill patients, but in the critically ill patients, that was not seen. And so that's led to a consensus guidelines based on sort of relatively uncertain evidence to use full dose anticoagulation in patients who are hospitalized but not in ICU, but then when they're in the ICU, to use standard dose prophylaxis.
Well, so that sets the stage for COVID-PACT. So where did COVID-PACT think it could make an impact, and what patient population did you study?
Yeah, so COVID-PACT was a 2x2 factorial randomized controlled trial in critically ill patients with COVID-19, so focused on patients who required ICU level care. And that included patients who were either physically admitted to the ICU or who were receiving ICU level care outside of the ICU, advanced respiratory support, vasopressor support, mechanical circulatory support. And they were randomized in a 1-to-1 allocation ratio to either treatment with full dose anticoagulation or standard dose prophylactic anticoagulation. There was an additional randomization to either clopidogrel or no antiplatelet therapy if patients were not already on antiplatelet therapy. And then patients were followed through hospital discharge or day 28 post-randomization. What was different about COVID-PACT compared to the multi-platform trial is the focus was on thrombotic events. So the primary efficacy endpoint was a composite of venous and arterial thrombotic events. And that was, I think, probably the biggest design difference in the studies.
Yeah, well, it makes a lot of sense, right? If we're thinking about antithrombotic and antiplatelet therapy, I can understand the interest in looking at really a clot outcome specifically. So what did the results show?
Yeah, so the results were very exciting. I'm obviously biased, but we enrolled 400 patients, and for the anticoagulation randomization, when comparing full dose anticoagulation to standard dose prophylactic anticoagulation, there was a 44% relative reduction in the risk of the primary efficacy endpoint, which was composite of venous and arterial thrombotic events. And that was a significant reduction. For the comparison of clopidogrel versus no antiplatelet therapy, there was no benefit of clopidogrel. In addition to looking at thrombotic endpoints, we looked at safety endpoints. And so, as you might expect, with the reduction in thrombotic events, there was an increased risk in bleeding. So there was 2 safety endpoints. The first was fatal or life-threatening bleeding. Fortunately, there were no fatal bleeding events in the study. There were numerically more life-threatening bleeds in patients who were treated with full-dose anticoagulation. That was not a statistically significant difference because there were such few events, but there was a numeric increase. But there was an increase in gusto moderate bleeding, which refers to bleedings that results in any transfusion, but without hemodynamic instability. So it does appear that there is a bit of a trade-off between a reduction in thrombotic events and an increase in bleeding that is not hemodynamically significant bleeding.
Yeah, well, I think it's an important contribution, and the fact that the antiplatelet therapy had no impact, I think is really notable as well, and perhaps provides some insights into the pathobiology of what's going on at the clot level.
Yeah.
So in your practice now, when you're attending in the ICU, do you think that this would change your approach to a critically ill COVID patient? Do you think that you would be treating them across the board with a full dose anticoagulant, or, because of the bleeding concerns, are you going to be more selective? And do you have any advice for people about, any patient groups who perhaps have the better net clinical benefit?
Yeah, no, I think that's exactly the question that we're all wondering about, and one that I have grappled with a lot over the last 2 years. I would say that what COVID-PACT supports is the efficacy of anticoagulation or full-dose anticoagulation for the reduction of thrombotic events. And I think it particularly helps because many clinicians have been scratching their heads about how to approach this difference between moderately ill patients and critically ill patients. Right now, guidelines suggest that you should put patients on full-dose anticoagulation when they're admitted to the hospital, but then when they get sick, do we stop it? What about that middle zone patient who's on high-flow nasal cannula? How do we handle that? And I think what we can say now is, with some confidence, is that continuing full-dose anticoagulation or starting full-dose anticoagulation when a patient goes to the ICU is going to reduce their thrombotic risk. It may not affect an organ failure endpoint, but it's going to reduce their thrombotic risk. I think you raised the obvious question, which is, does that true for everybody? And I think we have to be careful about patient selection. And I think it's helpful to think about who was excluded from COVID-PACT. Mm-hmm. So if patients were severely coagulopathic, if they were severely thrombocytopenic, they didn't end up in the study. If they were on dual antiplatelet therapy, in which case adding full-dose anticoagulation would give them triple therapy, they were excluded. So those patients are not ones I would use full-dose anticoagulation in. And then when we looked at patients who did bleed on full-dose anticoagulation, they tended to be quite a bit older than patients who did not bleed. And so that's a story that we've learned many times, mm-hmm. But I would have I would be careful in using it in elderly patients.
That's important. And I think that, always taking a look at clinical trial results in terms of who was excluded and who was included in their patient population is always an important thing to do. Well, thank you again for sharing these exciting results. I'm sure we'll see many analyses down the road as you continue to explore the data set, but congratulations.
Thank you, Michelle. It's great to be here.
Signing off from Medscape, this is Dr. Michelle O'Donoghue.